Good afternoon. I would like to thank the Society and the organizing committee for inviting me to speak this afternoon. My lecture for today is a topic that we as general anesthesiologists and subspecialists are all familiar with. My task is to present updates on the perioperative care of pediatric patients, as well as revisit known concepts and guidelines on the prevention and management of cardiorespiratory adverse events. I would like to disclose that I have no conflict of interest. To start, I want to show you this data based on an epidemiological study done in the US from 2016 to 2018. From this paper, approximately 4.7% of children aged 0 to 17 years underwent surgery annually. Extrapolated to the national level, this translates to about 3.1 to 3.9 million pediatric surgeries each year. They have also cited that in 2006, an estimated 16% or 450,000 in-hospital pediatric surgeries were done, compared to an estimated 2.3 million outpatient pediatric procedures. Going through our own census, in 2019, our local government hospital, the Southern Philippines Medical Center, have catered to over 1,200 pediatric surgeries. And in contrast to US data, 85% were in-hospital patients, while 15% were done as ambulatory procedures. Since there is a knowledge gap in the actual number of pediatric patients requiring anesthesia services in the country, I want to go through cardiorespiratory events more commonly encountered with in-hospital admissions first, then later those which are experienced in remote locations. Perioperative pediatric adverse events have been challenging to study within and across institutions. This is because when we talk of adverse events, we are sourcing data defined by the harm related to medical management, regardless of whether an error has occurred. Because less is known about the incidence of critical events compared to safety studies in pediatrics, creation of databases have been advocated as a means to evaluate critical events retrospectively, an example of which is the US-based study presented. This is in contrast to the prospective European-based apricot study that also aims to identify major risk factors for quality improvement and implementation of better practice standards. This study, conducted at the Children's Hospital of Philadelphia from 2010 to 2012, documented what is termed AN events, aka anesthesia now. Simply put, these are perioperative adverse events requiring rapid response assistance from anesthesia. In this 2-year study, they have documented 213 events, 2/3 of which are respiratory in nature, primarily laryngospasm, and is followed by cardiovascular events. They have found out that laryngospasm was reported in all phases of anesthesia care to all providers, regardless of experience, but was most frequent during emergence, with deep extubation cited as a contributing factor. 17% of laryngospasm events required a rapid response team in the recovery room, and it may be prudent to note that 60% of these cases were preceded by deep extubation. Bradycardia and bleeding comprise the majority of cardiovascular events. They have also noted that increased ASA physical status and involvement of multiple services increased risk of AN events, while increasing pediatric age and providers' experience reduced risk. About 92.5% of AN cases occurred in the operating room as compared to 7.5% in NORA locations. Based on their data, an AN event was 4 times more likely to occur in the OR than in remote sites. Mortality was related to increased ASA physical status of more than or equal to 3, and it should be mentioned that of the 5 deaths in this study, 4 were emergency procedures. The overall mortality rate during this 2-year study is 3.3 per 10,000 anesthetics, which is similar to other pediatric patients undergoing non-cardiac surgery. The apricot study done in 2014 to 2015 involved 33 European countries and included over 31,000 pediatric anesthesia procedures. Of the 30,000 participants, majority belong to the 1 to 5 year age group, followed by school children aged 6 to 12 years. Again, this study shows that respiratory events occur more frequently than cardiovascular events, and critical events in remote locations occur less frequently. General anesthesia was also associated with increased frequency of critical events than patients done under sedation. Going through the article, none of the reported deaths were anesthesia-related, with sepsis as the most common or the most frequent cause of death. Of the respiratory events, laryngospasm and bronchospasm topped the list at an incidence of 1.2% each, followed by postoperative stridor at 0.7%. Bronchial aspiration, which was rare, occurred more frequently in emergency situations. Based on the table, laryngospasm occurred more during emergence, followed by induction, and was mostly relieved by administration of propofol. Bronchospasm also showed a similar trend and occurred during emergence and induction. Treatment centered on administration of bronchodilators, deepening of anesthesia, with 4% warranting administration of epinephrine. 30% of post-op stridor events occurred in the PACU. Treatment involved application of CPAP, epinephrine, and administration of IV steroids, while bronchial aspiration was more frequent during induction. Still, it may happen at any point in anesthesia care. "94% of cardiac instability events went uneventful. However, for 5.5% of these cases, the outcome was poor, resulting to coagulopathies, cardiac arrest, and ICU admission. Plausible causes for the cardiac arrest were hypoxemia, low cardiac output, and hypotension. None of these children died during the perioperative period, but at 30 days, 30% succumbed to death. Majority of cardiovascular events occurred during maintenance of anesthesia with hypotension, arrhythmias, and bleeding. This was managed by fluid resuscitation, administration of vasopressors, and transfusion of blood products. Atropinization was done for bradycardia, and while overall arrhythmias had an incidence of 19%, only 1 out of 549 cases, or 0.2%, warranted defibrillation. The incidence of cardiovascular and respiratory critical events was significantly higher in neonates and infants and in patients ASA 3 and above. Age as a risk factor decreases by as much as 3 to 12% for each increasing year of age, while a history of prematurity doubles this risk. Interestingly enough, this study found evidence for the potential role of an experienced anesthesiologist who can decrease the occurrence of respiratory severe critical events by 1% for each year of his experience. While respiratory-related events were the most frequent complications reported in all age groups, cardiovascular incidents were predominantly reported in neonates and infants, and the protective role of an experienced anesthesiologist can again decrease the occurrence of cardiac events by 2% for each year of his experience. Comparing the apricot study with the AN study, the apricot study showed a higher incidence of severe critical events by as much as 13%. This may be because the AN study was based on retrospective analysis or voluntary self-reporting, which might have underestimated pediatric anesthesia morbidity. The composition of the anesthesia team has also been reported to decrease perioperative morbidity, suggesting that children with an ASA classification of 3 or more should be managed by tertiary care providers or by anesthesiologists with pediatric training. Now let's take a look at cardiac patients for non-cardiac surgery. This study, published in 2018, shows us a single institution's experience on this patient subset. And they have concluded that for cardiac patients, it is the perioperative cardiovascular events that is closely associated with patient functional status, as exemplified by lower incidence rates of respiratory adverse events. When dealing with cardiac patients, ventricular function assessed by echocardiogram within 6 months of the procedure is vital. Aside from assessment of their ASA physical status, we can also classify the CHD based on the residual lesion burden as well as functional status as defined by the American College of Surgeons. In this study, while over 70% of patients were classified as having mild CHD, majority still fall under ASA 3. Because cardiac arrest, arrhythmias, and pulmonary hypertension requiring treatment were rare events in this institution's cardiac patients, continuous requirement for inotrope was used to define cardiovascular events, which happened 99% of the time. On the other hand, respiratory events were not associated with the severity of CHD nor with the extent of ventricular dysfunction. Instead, they were associated with higher ASA physical status, head and neck surgeries, gastrointestinal procedures, general surgery, maxillofacial, and multi-specialty procedures, all of which involve manipulation of the airway and nearby structures. In summary, cardiovascular events are more common in cardiac patients, while respiratory causes of cardiac arrest were more frequent in patients without heart disease. It is also good to mention that for our critically ill children, bedside, or in our case, perioperative echocardiography, is a valuable tool that enables us to have real-time, rapid, and reliable diagnostic information necessary for clinical decision-making. For example, in assessing volume status intraoperatively or on whether to start inotropic support for cardiac dysfunction. Because PA catheters are of limited use in the pediatric population, a less invasive method of determining hemodynamic status like cardiac output and cardiac index, preload, and SVR can be done by means of transpulmonary thermodilution technique and arterial pulse contour analysis, or PICO. PICO, while expensive, is particularly useful in the management of hemodynamically unstable patients with uncertain volume status. Of course, in the hands of an expert echocardiographer, cardiac output and cardiac index can be obtained. Providing anesthesia outside the operating room is a challenging aspect of anesthesia care. The reluctance to provide anesthesia in an unfamiliar environment can be eliminated by understanding the patient's clinical and psychological problems, details of the procedure, degree of pain, whether the patient will be expected to lie absolutely still, and patient position. It is also important to check if the patient is a good candidate for an outpatient procedure in the first place. Respiratory depression, obstruction, and apnea are the most common complications, which, if unresolved, may be followed by hemodynamic and cardiac events. These adverse events are related to multiple drug use, inadequate monitoring, inadequate practitioner skills, and premature discharge of the patient. Note that even with recommended doses, all sedatives and narcotics can still cause problems, and children between 0 to 5 years of age are comparatively at a greater risk. Caring for the pediatric NORA patient should be no different from caring for pediatric patients requiring anesthesia in the OR. Thus, a comprehensive pre-anesthetic evaluation should be done, and we also have to be aware of the limitations of the pediatric procedural unit, as well as ensure the availability of equipment and resources. In this 2016 publication from the Children's Hospital of Philadelphia, rapid intervention from anesthesia at remote sites was commonly brought about by respiratory adverse events, primarily laryngospasm, followed by cardiovascular events. Anaphylactic reactions in the perioperative setting are rare, but can potentially lead to serious morbidity and/or mortality. The Wake Up Safe database is a registry for serious adverse events in pediatric anesthesia in the US. From 2010 to 2017, incidence of anaphylactic reactions was at 0.003%. It's very rare, and the most common triggers are antibiotics, followed by neuromuscular blocking agents and opioid analgesics. Newer NMBAs like rocuronium may be associated with more frequent allergic reactions than older NMBAs, while latex-related allergies are on a downtrend because of their elimination from the perioperative environment. It is also noteworthy to mention that children with cyanotic heart diseases may experience a decrease in SVR following contrast administration. Hence, timely intervention is necessary. PPLS, or Pediatric Perioperative Life Support, gives us a systematic approach to perioperative pediatric cardiac arrest, taking into account our familiarity and expertise in managing the airway, and are tailored to the nature of our profession in the perioperative and acute critical setting. In anesthesia practice, the perioperative pediatric cardiac arrest is witnessed, the patient is known to us, and the cause of the arrest specific and often reversible. Hence, with our knowledge of PPLS and our knowledge of PALS, or Pediatric Advanced Life Support, should enable us to manage rare causes of sudden arrest. The Asian Society of Pediatric Anesthesiologists, in collaboration with PSPA, have conducted ePPLS training, the most recent ones being held last September and November. And hopefully updates would soon be available online. I would also like to recommend the PediCrisis app, initially spearheaded by the Children's Hospital of Philadelphia and the Society for Pediatric Anesthesia. It is a simple, straightforward tool in managing the more common pediatric cardiovascular and respiratory adverse events. With this, I would like to thank you for your kind attention.